Hello, ACC 15. This is Jia Shen here with Dr. Albert Waldo. Thank you so much for
Hi.
joining us, sir.
My pleasure.
Being a famous physician as yourself, real notable guy in the field, where do you think the future of AFib therapy is taking us?
Well, I think we are still searching for um, the Rosetta Stone of atrial fibrillation. We have to understand its mechanism better, and then we can target atrial fibrillation for ablation. I mean, ablation is a wonderful tool, and it's been successful when we understood mechanism. The obvious examples: Wolff-Parkinson-White syndrome. We target the bypass pathway. We get the bypass pathway. It doesn't matter whether the PACs, all kinds of triggers. There's no reentry because there's no reentry circuit to engage.
Okay.
AV node reentry, you get the slow pathway. Atrial tachycardia, we get the focus. When we understand it, we don't know really what to do with atrial fibrillation beyond the fact that if you really successfully isolate the triggers, that seems to have the best shot, and particularly in people who have lone atrial fib, as we used to call it, that is people that in the underlying structural heart disease and who are young. I mean, if you look at the original trials, the Biosense Webster trial that they, with the latest catheter, the average age was 56 and they were all paroxysmal atrial fib. They did very well, relatively speaking. So, and we know that the longer you have atrial fib, things change. Remodeling does all sorts of things. So we really have to understand it. It's not simple. If it was simple, a lot of good people would have discovered the secrets a long time ago. So I think AFib is very important. And as we're living longer, more and more of our patients are having atrial fib. And the bottom line is we got to understand it more fully so we can direct our ablation. Well, let me just show you. There was a time when everyone was doing cafes, complex fracture figures, mostly because they were there, and not Amani thought that they were helpful. But after doing it a whole bunch, we realized that empiric approach wasn't enough.
Okay.
And there are a lot of people who challenge whether it was doing anything. I mean, that's just why even the lines that people put in, we're not sure what that does at all.
Okay.
And the only thing that we really know that has any real, I think, scientific background in making sense is the isolation of the pulmonary veins, because that's where the triggers, most of them are. That's not easy to do. And as we know, when AF recurs, we find that one or more of the pulmonary veins has reconnected, or maybe it never was disconnected from the atria. So,
okay. Well, awesome. Thank you so much, sir. And any advice for us fellows up and coming?
Oh, sure. It's a great field. It's a great thing to do. It's a lot of fun, and it's a thinking person's profession in medicine. You really have to understand things. You have to be logical in your approaches and careful. But it's a great field to be a part of. And there's a lot more to learn.